All right, we want to welcome you all back to our self-funded presentation. This is Garth Rouse with Professional Benefit Services, and today I've got Greg Jones with me. We're going to be starting here in just the next few minutes. Just to kind of go over, though, what we've gone through, we've got it's a four-part presentation. The very first one, of course, was going over the basics of self-funding. We did that July 12th, and today we wanted to go into all the relationships and give you an idea of, as far as the pricing and stuff is concerned, as far as the relationships and all the players involved in a self-funded plan. And then the next two will happen in September, October time period. We'll let you know when those things are planned. And those are really, the next two ones we'll be building on really what the savings are in these types of plans, and we'll go through some self-studies and some real examples of plan success stories of groups that we've administered. And then in the follow-up, the end will be the process of comparing self-funded to fully insured programs and the process of getting those groups started, that is, start the process of getting the proposals done. So giving you something you can compare to with clients when you sit down with them and look over all their options, fully insured versus self-funding plans. So with that, we'll go ahead and get into things. As I promised the last time, you won't have to sit and listen to my voice the whole time. Greg's with me, who really deals a lot in this side of the business with us. And he's got a lot more in-depth knowledge as far as the program goes. And so we'll do a little bit more of a back and forth today. Again, talking about those relationships, kind of the importance and what those are. To start out, it's really, I tell folks, probably most of you know that we do retirement plans here. We administer retirement plans. We administer flexible spending accounts, HSAs, COBRA administration, transportation plans, a lot of other kinds of things that we do here. And with most of those, the relationships are fairly simple. In fact, I was talking with a financial planner yesterday, and who hadn't been through this process before, and we were talking about a retirement plan. And I said, there's really three people involved in that. There is the plan sponsor, the person who wants to set up the plan for the benefit of their employees. There's the TPA, who handles all the administration, the 5500 tax form filing, all the administration of the plan. And then there's the investment advisor who brings in their investment options, where the money's going to be invested, and kind of pulls all that together. So really there's like three. It's similar on the cafeteria, HRA, HSA, COBRA side. There's really those three relationships. There can be more, but there tend to be three. Self-funded plans, of course, there's a lot more. There are a lot more relationships that have to be had. There's a lot of pieces that intricately work together. And so again, that's what we want to go over today. We want to do some just generalized kind of talking about the different players involved, things to look for when you're looking at working with a TPA, and also costs. I want to go over some of the costs. Cost is almost the first thing that comes up with groups. What's the cost difference? And so we want to address some of those type of things. So with that, we'll go ahead and get into this. So the next slide really deals with a third-party administrator, and the third-party administrator is really kind of the quarterback for the whole process of self-funding. They're the ones who kind of bring things together. They do the claim adjudication, appeals, payment processing, all the things that are listed here. And so, first, when looking for a TPA, I guess I'll ask Greg. Greg, what kinds of things do you look for in a TPA, or should people be looking for in a third-party administrator when they're looking at self-funded plans?
Yeah, one of the big things I'd look at is what types of services they can perform. You're going to want to find a TPA that can handle, all of the administrative tasks that you're really going to need to be done. But specifically, one of the good things to look at is their subrogation, how they're handling subrogation, how their accuracy of their claims processing. Do they do audits? What are the quality checks they have in place to ensure that they're appropriately processing claims? And again, how are they? And technology is certainly a critical part from a TPA. How are they exchanging data? If things are done manually, they're more prone to error. Obviously, there's going to be some inefficiencies in the system. if you're manually transmitting data between the various entities. So how data is handled, what their service model is potentially. Do they have a back house claims or claims processing staff that doesn't necessarily face the members? If so, there could be a little bit of disassociation between the customer service and the claims processing. So the customer service model is important, and how they structure it. In some cases, if you've got claims adjudicators answering the phone, it's not quite as efficient from a cost perspective, but from a customer service perspective, typically they deliver a lot higher quality service in the end. So I think several different factors. What do you need from a customer service standpoint? What type of employer are they? What are their level of need from a TPA? Some TPAs are designed almost as aggregators, where they've got a lot of efficient contracts in place to efficiently administer a self-funded health plan with minimal focus on customer service and actually servicing the members. So it really kind of depends exactly what your employer is looking for, but it's very important to really look at that TPA and see if they mesh well with your end client.
Great. So let's take a step back and just really kind of break this down. So let's walk through the life of a claim. Okay. So I go to the doctor and I see a doctor, he wants to do surgery. I hand him my card. The card says ABC company, or if the plan's self-insured. That information gets put into a system, and so that claim is now out there. Where does that go? Who touches that? I guess who's the first person to touch that? And when does the TPA get involved in that claim through the process?
Sure.
And so as you're explaining this, I know we'll be advancing to you probably talk about some of those other relationships, and go ahead and touch on those, and we'll talk about them later. But let's take me through the life of that claim as it just gets started.
Absolutely. So when a claim first comes in, typically, can come in electronically or via paper. Typically, a lot of times it's submitted through what's called a payer ID. I would say the majority, of claims, 85+% of claims, are going to come in through that payer ID, which is basically an electronic portal where the provider, medical service provider or dental provider, will enter in their basic information, basic claim information, that is somewhat validated on this portal. So if they enter in a member necessarily, if they enter a member ID that doesn't exist, it may not go through. So there is some validation that occurs to make sure it's a legitimate claim.
So just to stop real quick. So I'm there, I'm at the doctor's office, I have this procedure done. Are they, the folks at the doctor's office, are they entering this into electronically into a portal? Or they're okay, so they are sending it.
Yeah, so they've got an individual in the back office of these medical offices or hospital facilities that basically are going to be going through the chart notes and creating a claim based upon the chart notes. And so that's their entire job, is creating a claim based upon the services that they determined were done based upon the chart notes the provider actually did. So this is typically a clerical type of staff in a doctor's office that's going to do this. And they submit the claims typically, again, directly to the TPA for a self-funded plan. And again, usually that's going to come in electronically. At that point, the TPA is going to take it and pre-adjudicate it in many cases. So take a look at it, verify if it's eligible per the plan document provisions, verify, the provider network, various things of that nature, coordination of benefits, things along those lines. And once you've got a decent idea in terms of how the pre-adjudication is going to be done, at that point, typically you go out and you look at, okay, is it a network claim? Is it non-network claim? Does it need to be pre-certified? So in some cases, if the doctor hasn't had the claim pre-certified, or even if they have, we'll verify on our end and say, okay, well, based on the type of service we got in, this type of claim needs to be pre-certified. And so we'll reach out to our vendor on the pre-certification side and verify that the pre-certification has occurred. And so that's typically the process through the medical certification route. Depending on the type of claim, we may look out if it's a large inpatient or outpatient procedure. We may look at potentially immediately going out and negotiating that, whether it's in network or out of network. If there's not much that can be done there, in a lot of cases, the claim is going to be reprice based upon either the in-network repricing schedule. So typical services will have typical discounts applied. And so we literally will enter in the service and the amount that was billed on the service into a website hosted by the PPO. So if there's a PPO in place, and they'll reprice the claim, or we'll send the data to them electronically and they'll reprice it and then get it back. So it's one of those two methods for repricing, depending on what that provider can do. And then the claim comes in repriced. At that point, we typically will do the final adjudication, make sure that we're paying it per the plan documents, applying the member responsibility appropriately, deductibles, co-insurance, things of that nature, certain maxes if they're in place. And then we will prepare payment to the provider. We will prepare the EOB. And at that point, we will go back to the client and request funding, typically not on a claim-by-claim basis. Typically, we'll aggregate claims over a period of time, potentially a week or 2 weeks, aggregate those claims, send them to the client for approval, in which case usually it's just a quick approval process. There's not necessarily a lot of heavy lifting that needs to be done from the client. It's a pretty simple process. And then they go ahead and approve it, transfer the funding, and then we handle the payment to the providers and the dissemination of EOBs to the members.
Perfect. That's great. So then that's great explanation. And so can you give us any kind of timelines or guidelines that we like to use when a claim comes in and when it needs to be processed and out? And can some take longer, and what were the reasons some take longer?
Yeah, I would say 90% of the claims are processed and adjudicated typically within 6 weeks. So most of the claims are received and processed within 6 weeks of receipt of, but typically of the services performed. Providers are typically pretty anxious to get paid for them, so they're usually pretty good about remitting claims to us once we've got it. And then from our end, it's a pretty simple process when it comes to adjudicating the claim and getting it paid. If there's COB issues, potentially, if there's pre-certification issues.
So just real quick, so COB is coordination of benefits, yep. And that's where we're coordinating with other coverage the participant may have.
Correct. Okay. Yeah. So in some cases, we need to get previous EOB if we're a secondary payer. That's really always the case if you're a secondary or tertiary payer. Then you basically need to get documentation on the previous payments and what was paid and how it was paid so that we can determine exactly what we need to pay on those claims. If there's appeals that need to happen, again, depending on what can happen, claims can go as quickly as being processed within 2 weeks of service. In some cases, they can take up to 6 weeks for the majority of claims, but there are claims that can take, potentially even up to a year to get processed and paid. And usually that's due to an issue with submitting the claim. So the provider, in many cases, didn't submit the claim when they thought they had. The member ends up getting a balance bill notice or some kind of statement in the mail saying that they've got this large balance, what they thought their health insurance was going to get paid on. Then they contact us. Then we research it, get the claim, so those kind of things can happen. And it's very unusual, but it can delay claim payment to the providers. Now, there are provisions in the document that say, look, you've got to submit this claim in a timely fashion in order to be reimbursed. And it's really up to the document. In a lot of cases, we'll see 6 months, 9 months, a year on those kind of things to give providers an opportunity to submit the claim timely. And then if it's not submitted timely, they're really out of luck. So that the providers do have an onus to apply, basic provisions of the document, in which case, in many cases, they don't actually get the document. But by taking the insurance, there's a reasonable assumption on their part that they're going to be able to follow through with certain responsibilities that they need to follow through on in order to get paid. And so if that doesn't happen, usually a member can easily contest it, and the provider is going to be on the hook if, again, they didn't follow the appropriate steps.
Okay, great, thank you. So recently we were out talking with a group, potentially looking at self-funded, and one of the first questions that we were asked is one that we get asked the most, and what's the typical cost for a third-party administrator? And I think it's always helpful to be able to bring that right out of the gate so that people can kind of understand what those costs are. So let's just break down real quickly, just gut level of a premium dollar. So people know on a fully insured plan when they pay that premium, 100% of it goes to the carrier, who's then on the hook to pay out claims or whatever. So the premium is what the premium is. Let's on a self-funded plan, when we've got whatever the premium is, let's say $300, $400, $500, whatever it is, what percentage of that premium would go towards reinsurance carriers? We talked about those last time. We'll talk about them again in a minute. What percentage would go to the TPA? And then as we get to these other relationships here real quickly, I'll ask you to, again, just give us a cost, either as a percentage or potential, or just as a dollar figure, so that people can kind of get a handle on what these services cost.
Yeah.
So start with the TPA.
Yeah, absolutely. So a TPA is typically going to run, about 3%, right around there, 2 to 3% of your total plan cost. And now, again, I'm including claims so that we can compare it to a fully insured equivalent.
Yes.
So typically, it's going to be 2 to 3% of your total cost. Typically, it's going to be about. We see rates in the lower 48 of typically $25 ppm, and now we'll kind of get it into it at some point in the slides, but there can be rebates and revenue sharing that occurs that can artificially increase the cost. So while it may say $25 ppm, it's really important to read through these contracts to understand all their sources of revenue. Because again, the 2 to 3% is typically the fees that you see directly, but there can be some fees that are buried in there. But again, 2 to 3% is what you typically see from your total plan cost on a TPA.
Okay, perfect, great, thanks. So we're going to go ahead and I forgot to mention at the start, as you do, if you have any questions, feel free to go ahead and respond to those, at that time, or of course you can get to us back. I do believe that on your screen there is a place. Was it the upper right-hand corner? I'm trying to remember where it was, but I believe there's a place for you to access questions if you do have those. If you can't find it on your screen, of course, you can always email us at the office here, and I think we have our email address at the end as well. But the email address to send it to, certainly send it to me. I'm at gbrouse@profben.com, or you can send it to Greg, and his is GI Jones@profben.com.
And we'll after this webinar, we'll go ahead and send out a link to the webinar recording, as well as our contact information as well. So all of you who are on will have that.
Great. So thanks. So there's one of the pieces as a third-party administrator, and now we want to go ahead and get to one we spent a little time on last time: stop-loss carriers. So stop-loss carriers, as we mentioned last time, they're the folks that are the insurance on the insurance, right? So while employers are willing to take a potential risk with the plan, they certainly don't want to be at risk for huge expenses. And so, as we mentioned last time, there's really two kinds of stop loss that we see these plans have. One is a specific stop loss, that's on each person. So we're willing to take a risk. I, as an employer, willing to take a risk on Garth up to a certain level. We'll pay the claims. The employer will pay the claims on it. But once it hits a certain level, if something catastrophic happens to them, then we want a reinsurance to kick in. And so again, as we mentioned last time, we see those specific stop losses on any individual, $35,000 to $50,000 or more, depending upon the appetite, the size of the employer, and the appetite for that risk that they can take. So there's a specific stop loss, and then there's aggregate stop loss, which of course means once I've paid out a number of those specific stop loss situations, once we've paid out a number of those, we want to be done. So we want to be done on the individual level, and then aggregately we want to be done on the group level, paying out those claims. And so stop loss carriers are integral to really most all these types of plans, unless you're a super large group. So they're very integral. And so how does one go about, Greg, finding stop loss carriers? Is that something the broker can do? Is that something that the TPA does? How does that work?
Yeah, so it really depends. Certainly TPAs can do it. We help folks coordinate that all the time. Brokers can go direct. There are even stop loss brokers out there as another level that'll be able to shop your client across several stop loss vendors. So, a lot of times what we see is if there's a broker that's got a relationship with a stop loss carrier and a decent book, in many cases it behooves them to negotiate that, for that entire book, in which case the TPAs, can be out of the loop a little bit on that. Certainly providing data and everything needed in order to get that proposal and bid finalized. But in many cases, it is advantageous for an advisor to pool several of their groups together to negotiate and get better rates. So typically, if you've got 200 or 250 lives or more, you're going to be able to negotiate a bit of an advantage over those single contracts with stop loss carriers. For a TPA, again, we've got relationships with a lot of books. We can't bundle it ourselves just because of the nature of the work we do. We're really working with each client. It would not really necessarily be appropriate, and every TPA is different. I think most TPAs will typically not leverage their book because, again, it may not be at the best interest of each individual client when they're, from a TPA perspective with all the contracts we are dealing with. So again, TPAs are great on a one-off basis. Certainly, again, we get somewhat preferential pricing compared to advisors who don't necessarily have any business with a potential stop-loss carrier because of the other business we have placed with them potentially. But otherwise, it can be in the best interest of the advisor to go directly. Again, if they've got several groups that they want to pool together, there's certainly a lot more leverage that can occur with bigger blocks of folks.
Yeah, that's great. And so, again, one of the other questions again is cost of the stop loss insurance. And so I generally tell people that of your premium, again, back comparing the fully insured to the self-insured premium, as it were, if you're comparing those directly, and we say 3, maybe 4%, it goes to the TPA. In that, I typically tell people it's around 50% of the cost. So if I've got a $500 premium, then roughly half of that is going to go to stop loss carriers. Would you say that's fair, or did you change?
Yeah, it might be a little high. I mean, I typically would probably say anywhere from the mid 30s, 32, 33% up to the mid 40s is a typical range, for total stop loss premiums, depending again on how much risk that the client is willing to take.
Okay, so as we break out, we want people to have a good kind of inside look into this and how these things are built and where those costs are. So again, comparing a fully insured premium to a self-insured, if 30, 35, maybe 40% goes to the stop loss carrier, you're talking about another 3, maybe 4% to the TPA. And then there's a certain other percentage, right, that we might come to, which would be another maybe 5% or 6%, somewhere around there. And then the rest of that would be in claims, right, and what we'd anticipate in claims. Would that be correct?
Yeah. So claims are typically going to be, the other 55%, so I'd say, it's going to be about 55% of your total costs are going to be claims. I'd say generally 35% you'll be sitting on the stop loss, 2 to 3% with a TPA, the PPO network, if you're, renting one versus, reference-based pricing, either way, you're probably going to see another 2 to 3% there. You've got, advisor commissions, which we like to, keep, very comparably to the fully insured prices.
Right.
So, and then, but all in all, that's probably a good breakdown of what the spread's going to look like.
Great. Thanks. And then so how do we find, or how do we determine, what stop loss carriers would be appropriate? And so I'll ask you for a few thoughts that you might have on that, Greg. Of course, there are always rating services out there, right? And you can get rating services on carriers to find out, who might be somebody that you'd want to do business with. Do you have any other key points or anything you would bring out in that?
So certainly the rating services are important. You want to find out the financial, the financial backing of these firms, right? You don't want to end up, having a stop loss carrier go belly up, and then, you're in a lot of trouble. So you want to make sure they've got a strong financial rating, which, typically those things are well publicized. The other thing I'd say is, you really want to make sure you read the contracts thoroughly, because every stop loss contract is not written the exact same. I mean, there's certainly, things like incurred date and paid date, which are really standards across the industry. But in addition to that, there can be nuanced provisions in stop loss contracts that dictate very specific things that don't necessarily mesh with the plan document. So how long, providers have to submit a claim, appeals process sometimes. There can be certain things potentially that your plan may allow for that specifically a stop loss is going to carve out. So for example, bariatric surgery potentially, or certain things along those lines. There may be provisions in the stop loss contract that would prevent them from reimbursing that, whereas you may have a plan that allows for it. So it's really important to make sure that the contracts do mesh, that your document and your stop loss contracts mesh. Outside of that, really, you really want to go and have several options out there because in 1 year, there's some certain stop loss companies that are buying business and they're getting very competitive. Just like what you see on the fully insured market. In some years, you see, some that are really not interested in being very competitive and their rates are not very aggressive. So you've got to be ready to move that component and shift it when need be. But the nice thing is when you do it with a self-funded plan, there's very little interruption. When you shift out a stop loss provider, there's very little notice, if any at all, to the member and to the plan sponsor. So it's usually a pretty seamless process and a way to keep folks very competitive on the risk component.
Okay, great. So one last thing, we'll have to move on here. We're running out of time with this, and we'll get on to networks and talk a little bit about networks and how and why. But one thing, there is, I would say, from what I've seen, there is a unique relationship, I think, between the TPA and the stop loss carrier, in that you want to make sure that they work well together. That for really a lot of reasons, the stop loss carrier has to be confident in what the TPA is doing, right? And in being able to provide good input, to be able to provide timely input so that the stop loss carrier doesn't feel like there may be claims out there that they're going to have to pay on. Can you elaborate on that a little bit, maybe with some examples of some folks we've worked with in the past?
Yeah, absolutely. So the stop loss carrier does want to make sure that they've got a good TPA working on a plan, for the exact reasons you mentioned. You don't want claims being lost, in the system where they got submitted, and then, because these claims do go through a pretty complex process between repricing, between medical management, and potentially other services involved. It can be routed, especially during the appeals process. It can, bounce around, quite a few places. And so it's really important that the TPA has an efficient system for tracking these things, adjudicating claims. Obviously, if there was a high denial rate, so if the TPA was inappropriately denying claims, which can happen, because again, if TPAs keep plan costs low, that looks good on the TPA, but there could be a bunch of liability hanging out there because potentially there's claims that are being denied that really should be approved, and that risk falls on the employer. It also falls on the stop loss carrier, depending on how the contracts are written. So they really want to make sure they've got TPAs that are leveraging best practice and claims adjudication, things of that nature. But in addition to that, it's the vendors that those TPAs are using as well. Because in many cases, the TPAs are selecting many of the other vendors, medical management, PPO network, potentially secondary RAP negotiations, various services like this, which will dramatically increase the potential cost or may dramatically affect the cost of the claim. So it's very important to have a good relationship with the TPA and the particular stop loss carrier. And there's certainly going to be a vetting process if the TPA is new to it. There will be some vetting to go through with that stop loss carrier to make sure that, again, that stop loss carrier isn't incurring any unnecessary risk by working with the TPA who they haven't worked with in the past.
Yeah, so important relationship, important that they be able to work together. So thanks for that, Craig. So let's get on now to the next relationship, which is networks. So for those of you that don't, I'm sure you all know, but just to go by, make sure we're not undercovering anything. But the network, of course, is the network that you're of physicians, of providers that you would buy or you would add to a plan in order to have a provider network for your employees to be able to access. Networks are really important, I think, from a participant standpoint for a couple of reasons. Right? And one of those is, first of all, there's a comfort with folks. One of the first things, as you all know, whenever you're changing medical plans, the question always is benefits and cost, right? There has to be a good relationship there between benefits and cost for people to be excited about the plan. But one of the first things, whenever I go in and talk to a new group about, and we're changing the plan, they always want to know, of course, is their doctor on the network, right? We all love our doctors. We want to make sure they're on the network. And so there's a comfort in that. Always the first question that people have is, what network are you using? And so it's also networks they're very easy for providers to understand at the point of purchase, right? So when I go in and see my doctor and they take a look at the card, if they see a network, then typically there's not any problem. There's no pushback with billing and getting into the system and processing that claim. So from the participant standpoint, networks are a key part of any medical plan. There can be downsides, though, to networks as well. And so, so let's talk just real quick about the pros of networks. Again, are you do get providers. The providers are contracted to provide services at a discounted rate, which means you get a discount. And so that's one of the positives for the plan. What most of you may or may not know is the discounts you get with carriers. We're finding we use a claims claims adjudication service. I don't know how to they reprice claims, and they negotiate out of network claims. And what we're finding is we're getting actually discounts that are very similar to in network. So where we may end up getting 25 or 30% on in-network discounted costs on those procedures, we're finding the same thing with the stuff that's negotiated on the out-of-network side. The benefit to using a network is that you don't have any balance billing, which is the fourth bullet point down the slide. There's no balance billing. So when I've contracted with a network and we're sending our people to utilize those providers, their contract is so that they're going to provide it at a discount, and there's not going to be any balance billing. And so from that standpoint, that's a nice protection for the participant. The downside of networks is when you're looking at employing reference-based pricing, which is the fifth bullet point that you're looking at. That RBP is reference-based pricing, and I would wager to guess most of you have heard about it. It's been around a lot as self-funded plans have continued to grow. Reference-based pricing is a strategy that a lot of people are talking about, and they're exploring as a way to help control costs. And so just a real quick definition, reference-based pricing, what they're doing there is they're just taking a percentage of Medicare costs, and they're saying this is what we're going to pay. And so a lot of you may, again, something you may or may not know, but the pricing with providers can run anywhere from 100 or 150% of Medicare pricing all the way up to, we've seen 600%. Mm-hmm. I don't think I've seen anything higher than that, but 600% of the Medicare pricing. And so reference-based pricing just says, look, we're not going to pay that. We're not going to pay that 600%. We're going to hit everything at 100, 150% of what Medicare pays, and that's what we're going to pay. And so that's the downside to that. Well, first off, in a network, the reason reference-based pricing is difficult is because the providers have already contracted with the network to provide at a certain cost. So they're going to price, their prices are set. They're not set at a percentage of Medicare or whatever you want to do with reference-based pricing. So they're set at whatever they are. So do you have an example of that, Greg? I think we talked a little while ago, the example of a provider and what they charged on a procedure, and where Medicare, if we did reference-based pricing, would have been less.
Yeah, absolutely. We've got procedures all the time. I guess the best example I think would be a case where we removed someone due to the pricing difference. And so, we had a service that was to be done in Anchorage at a Providence facility, and that service was estimated to cost $165,000 without. Now that was facility, that was the primary surgeon. But that did not cover the anesthesiologist or potential assistant surgeons and things of that nature. So likely about a $200,000 claim, it would have been, but we had a quoted at least $165,000. And then we were able to go down to Northern California and negotiate a rate of $65,000 for all services included. So that kind of gives you an idea of the pricing disparity. But in aeromedevac situations, where you've got large aeromedevac expenses, it can vary dramatically. I mean, we'll see some folks charging 100% of Medicare, at $5,000 per particular flight. We've seen that exact same flight I'm charged $50,000. And again, 500% of Medicare. So every facility is different, every provider is different, and it can be pretty wild, the kind of disparity you see. And the concern I have with PPO networks, specifically, is they're driven by a percentage of savings. And so if the hospital charges higher rates and then gives them a deeper discount, it looks better for them. But what if you go to a facility across the street that isn't playing that same game? So we'll say facility A is charging $100,000, but they're going to give a $60,000 savings to
discount
to Cigna.
Right.
So it ends up being $40,000 to go to Cigna. Well, if the facility across the street is charging, we'll say, $40,000 street rates, and we can get them down to $25,000, just individual negotiation. Now it looks like a 40% savings. However, 25,000 is less than 40. So, some of the games that these providers will play and the large networks will play on the savings is a little bit of a misnomer. So I think it's PPO networks can be helpful, can be great strategies to use, but you really want to understand exactly what it is and what you're getting and what they're selling to you. Because again, I'm not a big believer in the percentage of savings, especially because I've seen it modeled with duplicate claims, and things of that nature. So I think the data can be manipulated to tell the story they want it to tell. But networks can be very valuable. And honestly, when looking at networks, it's important to understand, how wide, how broad of a network do you need? Usually, again, broader networks are going to cost you more, or you're going to get less savings, or potentially a combination of both. But it will, again, give you protection across the country, potentially, depending on the client. You can do, more smaller networks. I wouldn't call them narrow networks, but smaller, more regionalized networks. So the example that would be like First Choice Health in the Northwest. They focus really on Washington, Oregon, Idaho, Nevada, just a few states basically where they're really focusing on. They give solid discounts in that region, but you're not going to be able to get them in the Northeast or the Southwest or the Midwest.
So geography is a big reason to choose a network.
Yeah.
To find out which network is strong. And so how would folks know, how would folks out there know about which networks should be used? That'd be something you depend on your TPA for.
Yes, yeah, you'd get a claim history to your TPA that would basically contain the TINs of all the providers they've used. And then that TPA could get an analysis done to show you what networks are going to give you what type of coverage. So typically they'll say, hey, we've got, all these providers are in the network. Sometimes we can just look at zip codes of employees. If we don't necessarily have claim history, we can look at zip codes of the employees and the proximity of providers to those employees' residences. So there's various ways of looking at it and finding an appropriate, strategy depending on the employees. Now, additionally, what I'd say is you really have to factor in what the employer is really looking for. If they're wanting to make sure the employees have, have excellent access and aren't as concerned about cost, the broad networks are great. If, again, they really want to cut costs and are okay with driving their employees to a smaller network, the narrow networks can save dramatic. I mean, we see 60 to 70% savings potentially on narrow networks. And again, using those type of narrow networks with much more limited range, but much deeper discounts can really save a lot of money to the plans and minimally inconvenience the members if the client's got the appropriate demographics for it. And additionally, what I'd say is the reference-based pricing strategy can be really effective. Not a big fan of the Medicare reference-based pricing, but there's a lot of folks out there who do cost plus reference-based pricing. So they'll get the schedules on the exact cost schedules from the hospitals and determine exactly the fixed costs that were incurred by a particular facility on a particular claim, and then they'll increase it a certain amount for basically they'll pay them enough so they don't appeal, but they won't pay them so much that again the savings aren't there versus having a network.
Yeah, so there's a lot of strategies and a lot of things to take into account in keeping these costs, keeping the costs down on the medical side and keeping this affordable for the employers. So last thing I'll mention, Greg, and so again, if you want any further conversation on those, talk to Greg or I about that. Last thing, just real quickly, because we have to move on, real quickly, cost for networks. What's the low and what's the high? You don't have to mention them, but what are you seeing as far as cost for the network so we can get back to that premium analysis?
Yeah, so many times it's a PPM cost,
yes,
with networks. So a lot of times we'll see it down to as low as $3, which I think is fairly low.
$3 ppm.
$3 ppm. Usually $5 ppm, somewhere in that range. For some of the bigger networks, especially the ASO guys like Cigna and Aetna and those kind of folks, to get to those networks, you're usually talking $15 ppm in that range, with a lot more requirements built in.
Perfect. Okay, thank you. So that goes through the network. Now let's get into the claims negotiation. So this is a piece again. What we do is we want to make sure that every claim that comes through, because again, our focus here is to make sure that the cost stays in line for folks. So we want to make sure that we're wringing as much as we can out of these claims that come through. And so we're now getting into the claims negotiated stuff. So we're talking about stuff that's out of network claims. So the folks that we use, first, Greg, just real quick. Well, let's get into. So how a claim comes in and it gets it gets priced through the provider network. If it's in a provider network, it gets priced that way, and the way it goes. If it's not in the provider network, it's an out of network claim. Tell me what happens with that claim. We send it off to our claims negotiation group, and then what do they do with it?
Yeah, absolutely. So our claims negotiation group will then go ahead and reach out to the provider and see what what kind of an agreement they can come to on that individually negotiated claim. And so really the plan document says that, typically we're going to see UCR, usual and customary is going to be the method of payment for out-of-network claims. And with the UCR, with the usual and customary, there are a lot of different tables that use a lot of different methodologies that you can pull from in order to justify your claims. Now, you want to be consistent in the methodologies and things of that nature, but there is some flexibility there, which gives you the opportunity to negotiate with the provider to potentially get rates below UCR and avoid balance billing. And so if we get an out-of-network claim, a lot of times we'll go to that provider and we will aggressively negotiate with them to get them to settle for below UCR and avoid a member balance bill.
So then describe what's a wrap network and how does that fit into this process?
Sure. So wrap networks, a lot of times wrap network is a secondary, I guess the best way to think about it is a secondary PPO network. So whenever you've got a primary PPO network, you get certain savings because you're driving your membership base to that provider network and incentivizing them to go to it. So there's some large savings that can be had because those providers are willing to give more substantial discounts in exchange for the increase in volume. With the secondary networks, they really you're not going to be driven. In most cases, you're not going to see their logo on the ID card. You still may, but in most cases you don't. And so when you're not steering members to them, they're still able to save you discounts. And a lot of times these secondary wrap networks rely on their PPO networks in order just to get these secondary savings. So it's somewhat a byproduct of their primary PPO network. But these wrap networks basically get a lower savings, but you do get contracted savings that you wouldn't otherwise get on a claim for these out-of-network claims. So we've got agreements with various networks. So if somehow we got a claim that hits that network, even though it's not a network claim, we'll receive savings not as good as if it was the PPO network, but somewhere in between. And in many cases, those are excellent to use for the lower dollar claims. It's simply not worth anyone's time to reach out and negotiate a $200 claim. You really can't pay the people enough to do that. But a wrap network, they'll save you 25, 30%, and there you go. Sometimes 15%. Usually, again, they're doctor's office visits, things of that nature, potentially certain diagnostics that are done where you may use wrap networks. But by and large, anything with a substantial dollar amount, you're going to negotiate directly. And I should say the PPOs are going to typically save you, 30 to 40%, hopefully pushing 40%. And then, our out-of-network so far sits usually about 40%, sometimes up, depending. I mean, if we do individual negotiations in advance of a service actually being performed, we can get 70% savings in many cases. It really kind of depends. But
so it's back to that we're seeing, and again, this may be a surprise to some of you. It certainly was to me, but that you can get as much of a discount in your out-of-network claims as you can in your provider network. So let's talk about how they're paid. We had mentioned that the provider networks are paid on a PEPM. How are these services paid for?
Yeah, these folks are almost always paid on a percentage of savings. And so basically they negotiate a discount off the stated charges, and then they get a percentage of those savings. So that can range anywhere from, usually what we see is 20 to 25% for the percentage of savings that you're going to pay that provider. In some cases, it can be more or less depending on exactly what they're doing, but usually that's about what you see, somewhere in that range. And then basically they'll take a percentage of the claims that they save on your behalf.
Which is,
or the-
yeah, which is great. What I like about, and some people will like that, some people won't. There's a number of different options as far as the way you can pay these folks. I believe they have a PEPM rate too, or do
In
they
many
not?
cases, they don't.
Okay.
And because again, I think you want to keep these folks incentivized to save as much money as humanly possible.
You do, and I think that's what I like about it is that it's the incentives are in the right spot, right? They're gonna get rewarded for the more that they can, that they can save, and as long as it doesn't hurt the participant, we kind of want to go that way. So again, we're kind of coming up on our time limit here, and so we have got just a few more things to go through. So we'll go into the next utilization review and then medical management. So tell me just real quick what that is and when does it get used? As in a claim comes in, and how does it get to utilization management folks, and what do they do with it?
Yeah, so typically it's actually before the claim comes in. Usually the doctor is going to say, a member is going to go into that provider and say, hey, I need to get this knee surgery done, we'll say. And so the doctor says, okay, well, they go through the medical records. Yeah, it's necessary. Well, they have to contact, and this is fully insured and self-funded plans. It's really a similar process. They've got to contact an entity and basically verify with that entity that it is necessary. So some doctors can be a little rogue and can, on occasion, see an orthopedic specialist, pushing a procedure, well, because they get paid on it. When it doesn't necessarily need to be done, or there haven't been certain steps that really should be done beforehand. So you've got a company, usually some TPAs have it in-house. Most TPAs have an external medical management company that has specialized nurses on facility, a lot of on staff. They basically review everything against national guidelines and say, okay, the member has done everything they should be doing to avoid surgery. In some cases, when there's back issues, you look at alternative physical therapy, you look at, alternative therapies prior to going down the surgical route. Potentially the same with knee surgeries, but it's not quite as variable. So you basically go through a process where you verify, is this procedure necessary? And if it's not, again, you go back and you tell them, hey, it's not necessary. These are the things you need to do, in order to qualify it. And it may mean alternative therapies. It may just mean that, hey, look, this is not appropriate therapy for this type of a diagnosis in general. So, that process occurs. There can be a back and forth, potentially, that you'll have a nonpartisan physician who will review it with the member's physician and go through everything, that it can go up to that level. You can even have an external appeal if again, the two parties aren't kind of aligning. But typically that's what that utilization review medical management company is going to do, is they're going to verify that the claims that are occurring, that they're a medical necessity.
Okay, perfect. And so, again, back to the cost. Is this a PEPM kind of a thing, or has that?
Yeah, so usually you're going to see, it's a PEPM thing. And I'd say for the standard services you see done, you see $250 to $3 an hour, or $3 a PPM, for kind of the standard pre-cert and basic case management items. And then typically you see an hourly rate for the medical case management when you have folks that are watching and reviewing the major procedures to make sure that they're done right, that the bill is appropriate, that we're not being overbilled based upon chart notes. So there's a whole level of review that's done on significant claims to make sure that they're appropriate, necessary, and that we're not being billed for things that weren't done.
Perfect, thanks. So we just have a couple more slides here, and so I want to get into these, and I think we're getting close to our time here. So let's head in next to Pharmacy Benefit Manager, PBM. And so talk about the difference between PBM and what happens there versus the claims that come through on the medical side, right? Who sees them? How do they process them? And give us a little background on the Pharmacy Benefit Manager.
Sure. Yeah. So the pharmacy claims are typically submitted directly to the PBM, whoever it is. So Walgreens or Walmart or whoever, they're going to submit the claim. They'll have the information on file, and they'll submit it directly to that PBM, and that PBM will reprice the claim. As the TPA would typically handle on a medical claim. They'll reprice it per their contracts. Then they'll go ahead and pay that pharmacy, and then pay the TPA, or then bill the TPA, and as well as provide claim information back to the TPA so that we can make sure that information is adjudicated in our system and applied, to whatever appropriate out-of-pockets or limits.
So when we get the download feed from the PBM, that'll go into our medical management system. So it'll coordinate with the EOB, right? Or all,
Yeah. Yep. Exactly.
So it all reporting so that people, not the participants, but the employer can see, and when they take a look at their claims, right, what was paid out, that's separated medical versus pharmaceutical, and it's all broken down by, again, along those lines.
Yeah. And so the big part of the PBM, the whole reason the PBMs really came into existence is formulary management. So that is certainly a critical component of what PBMs do today is, which drugs should be on generic, which ones should be on specialty, formula, and basically making sure that you've got, appropriate, financial incentives in place so that members aren't necessarily getting incredibly expensive drugs when there could be a cheaper alternative in place. And so that, that formulary management is a big part of what they do, and recommending, which formulary to use, or just providing various formularies that can be adopted. And I should mention the other thing that they'll perform that we don't do, that we do separately on the medical side, but they handle is the pre-certification process. So, if someone needs a prior authorization for a prescription because the diagnosis doesn't necessarily meet, a certain guidelines for the particular prescription, then they'll vet that through and make sure that either A, it should be, reviewed everything, and hey, it's okay to go ahead and dispense that medication, or no, look, you guys really need to look at trying this drug first, potentially. Again, all depending on what the plan is selected for a formulary and what their plan document says.
Okay, great. So the other thing that's more and more of this stuff is coming to light. I know the president had a proposal not long ago where he wanted to be able to shed more light on what PBMs charge and how they process their claims, and just shed light on that whole process. Part of that is rebates. And so we talk about rebates. We get revenue sharing on retirement plans. And one of our practices here, right, as far as the TPA, is to always declare what that is and let people know what those are and how they get applied. And we have that same situation with the PBM. And how different are the rebates that you get from different providers, PBM providers?
They can be dramatically different. So we did an aggregate contract with some of our clients at Magellan, and the rebates were threefold between the Magellan and the Optum contract. So if we kept all the rebates as a TPA, the Optum contract would have been more advantageous for the client due to the way that there were some cost savings that were occurring on the Magellan contract that were greater than the Optum contract. But when you factor in the rebates, it wouldn't be a cost-effective switch necessarily to go to Magellan, from Optum in this particular analysis. Now, we did it because we credit all the rebates back. And so crediting the rebates back then actually it created about a 10% net cost difference between the two PBMs. So rebates and how they're structured can be incredibly varied and variable depending on again, the strategy that PBM is using to attempt to acquire business. Typically, I would say rebates are bad. Again, we credit it back, so it's kind of worked out to our advantage. But the rebate, the whole point of it is to incentivize service providers to bring them business that's in their best interest, not necessarily their client's best interest. And so in some cases, advisors are getting these rebates. In some cases, TPAs are getting them. So really the most important thing is to be aware of them because, again, they're part of the industry. If you've got them in your contracts, it's not necessarily a bad thing. Again, you just want to look at that whole picture because we, in plenty of our contracts, we've got them in there. But again, we credit our clients back. So that in the end, when they're looking at their net costs, we want to make sure that every decision we make is in their best interest. And so it's really important in looking at that. And there can be, there's a big wave of transparent PBMs out there, which can be very cost effective as well. The thing to watch out for is when you get into their contracts, you'll see potentially much lower or much greater savings potentially on a drug by drug basis. But what you don't necessarily get, you're going to get typically much higher dispensing fees and administration costs associated with it because while they need to collect the total revenue direct as opposed to getting it through rebates. And so it's a really tricky area to evaluate because we never really know what the PBMs are paying the pharmacists the pharmacies, and that's really a critical part because there's a lot of spread pricing that occurs. So they'll tell us, the TPA and the client, that it's going to be X dollar amount. We'll say $50 for a particular prescription, but then they may only pay the pharmacy $30, so they make $20 on that script plus whatever fees they have built into the contract. And so the spread pricing with PBMs is one of the bigger problems in the industry, and it's something that honestly, even if you get great contracts and everything, it can be really challenging to understand. So what I would recommend, if you're looking at changing PBMs or evaluating them, have them do repricing analysis on your claims, based upon the contract you're discussing, and it should give you an idea of what total potential savings there are if everything remains fairly comparable.
Okay, perfect. Thanks. So there's a lot more that can be said about PBMs. There's a lot more to know about that whole industry, and I think a lot more light's can be shed on some things there as we move down this timeline with healthcare in the U.S. Health insurance. So last thing, again, we're pretty much kind of out of time. Just real quick, Greg, analytical tools. I know we don't need to say the name of the analytical tool we use. Let's just focus on that real quick and just describe real quickly. So what these analytical tools will do, it's software that we can download the experience of our clients into, and then it takes a look at that data, manipulates it, and what does it tell us? What kinds of things can it tell us?
Absolutely. So basically, these folks are large actuarial firms that have basically large data repositories for medical claims of members. Members that are independent of your firm so basically we've got hundreds of thousands of medical claims and member histories, of which basically they can leverage. We take our data, so we basically take claims feeds from our system and feed it to them, and then they analyze that data, and they're able to predict with a fairly high level of accuracy what the costs are going to be for each one of your the potential conditions you've got within your group. So you've got cardiovascular disease, and this software will say, hey, this year it's costing you X dollar amount. Next year it could potentially cost you, X plus 10%, we'll say. So it can give you a very strong ability to see exactly where your costs are, what conditions are driving your costs, and give you some predictive capability to understand what it's going to look like next year if, again, everything kind of holds true. It can give you breakdowns by member groups. So how much am I paying for dependents, which can help you understand, am I charging enough for dependents coming onto the plan? Mm-hmm. Where are your costs being driven? How are they being driven? What are your biggest potential risks in terms of costs? And you can even drill down to an individual and say, there is a 95% likelihood that this individual is going to go to the emergency room within the next 2 years. And there's those kind of capabilities that this software is able to identify and basically give you an idea of what's going to happen before it happens. And so it really helps plans, and this kind of rolls into the next thing, but developing wellness programs. So in some cases, you can pay for services that will proactively reach out to your members and encourage them to do certain things based upon our data to improve their health. It might be that they've got a couple of prescriptions that could easily be consolidated into one. In some cases, it might be, hey, you've got a diagnosis for a certain condition, but you're not seeing anyone to have it treated. It's much easier to prevent, a substantial event by preventative treatment than it is to deal with it after it's occurred. So someone with high blood pressure is not taking their high blood pressure medication. Well, it's going to cost you a lot more in a cardiac event than it will just taking their blood pressure meds. So you can do those kind of things. You can do wellness programs that just generally, improve certain things. If you got a class of employees that's diabetic, that you can do potentially some, education on diets and exercise and things of that nature.
Yeah, so I'll tell you the stuff that really excited me about the analytical tools. Again, being able to, if you could get to the place where you could, with a certain degree, there's always going to be some, risk that's not measured or seen that's going to pop up in a year or 2 years or whatever. But if you could, with, some measure of certainty, know kind of what my claims are going to be next year, or at least project to what those are going to be, that's really powerful. And to me, to be able, if you could go to your employer, how many of you wish you could go to your employer and go, look, here's what the cost is going to be next year. And furthermore, it's because of these conditions, and here's how we can control it. All of that is, to me, is incredibly powerful and something really, really valuable. And once again, you only get that by knowing what's going on in your group, knowing the health of your group, and which means self-insured. That's the way you buy all that information and know about your folks. You don't get that in a fully insured plan. So, anyway, I want to thank you. We're really at the end of our time here. Thanks, Greg, for joining me on this. Thanks for joining us. Here's our website. Visit us there. Or if you have questions, feel free to get a hold of us. I will mention to all of you, we anticipate CE for this. It's been filed. We haven't heard back yet. We did have CE for the previous webinar that you've attended. I've uploaded that information. So that's everybody that attended the roster. So I think everybody there should be seeing that. If not now, should be seeing that very soon. So again, we anticipate that. Please follow up back with us if you would like. Otherwise, look forward to some more webinars. We've got a couple more coming down the pike. Next one will be in September. We'll email you about that. And again, we're going to talk about case studies, some real world studies of how people have saved money moving to self-insured. And then we'll go through the process of how do you get a proposal and getting groups set up. So thanks again for joining us today. We hope everybody had a great 4th. Hope you enjoy the rest of your summer, and we'll be back with you in the fall.
Thanks everyone.
Thank you so much. So I guess this is how.
Yeah.